can help with the sensitivity and that type 2 that is in the genitourinary skin specifically.
Someone here asks, can you, perhaps give an example of how you look at evaluation and treatment of someone with post-finasteride syndrome? We get a lot of questions like this.
A lot of questions. And we do have a lot of patients with PFS. And I think we've talked about it, or at least talked about finasteride and dutasteride at length. A lot of it's an individualized approach. I think people know I use kind of like an X and a Y axis. So with PCOS, you have an X axis and a Y axis, and actually a Z axis too. And with PCOS, just for reference, it's androgen dominance and insulin resistance. Whereas with PFS, it's kind of androgen, I don't want to say indominance, but androgen insensitivity and genitourinary symptoms, and then also neurosteroidal symptoms or CNS symptoms. So CNS symptoms would have to do with the balance between fight or flight and rest and digest. Those are called sympathetic nervous systems and parasympathetic nervous systems. You have your sympathetic ganglion, for example, stellate ganglion. So some people get stellate ganglion blocks with good result. And then you also have your parasympathetic nerve. Vagus nerve is actually a cranial nerve, 10, that comes down and innervates your heart. Has to do with heart rate. It's called parasympathetic tone, and also innervates your gut, oddly enough. So there's a one tie-in for gut-brain axis with a direct line in between it. Not that we need more information to support gut-brain, but that is certainly like part of the CNS. A lot of people talk about neurosteroids. It's not just DHP and THP. Yes, there's a lymphatically absorbed allopregnanolone in development, but we also know that just pregnenolone supplementation or progesterone supplementation will lead to 5-alpha reduction, especially when it goes through first pass and then cross the blood-brain barrier. So you're obviously looking at those molecules as well. And then as far as the genitourinary system, there's a lot of different things that we can look at, but there's actually pretty good data on people who have gone through ADT or androgen deprivation therapy. Not the exact same thing, but you can definitely make some corollaries. It's nice that there's a huge pool of evidence to look at. And I don't know if many experts are looking at this, but we are certainly looking at it a lot. And optimizing your testosterone and DHT, like we often talk about, can help with the sensitivity and that type 2 that is in the genitourinary skin specifically. And we will dive into this consistently over time, but that's definitely something to consider. PRP shots. People are familiar with like vaginal rejuvenation. There is a male version of that can be useful as well. That probably doesn't even cover half of it, but basically we do an individualized approach like we do with everything else. And that's a bunch of various things that we've had mixed success with.
Yeah. There's certainly no promise of a cure if someone presents with something like this. And the other thing is, hormone optimization in looking at this starts with the blood work. So it's really a diagnosis of exclusion. Some people, they may think that they have PFS and they actually just have a profound hypothyroid state that's leading to a hypogonadal state. And then you just sort of undo the cascade there. And then the, PFS in that case is cured. Mm-hmm. But there are cases where, no one wants to hear, well, get your labs checked and this, or like everything's normal. Just tell me the mechanism, tell me the stuff. And, HCG is something that can be used there. And interestingly, HCG seems to affect the type 2 5-alpha reductase. We came across a great gem of a paper recently, but not in the direction that you might think. So we'll certainly have perhaps a full podcast on that at some point as well.